We are your hosts, Nicki Shorr and Jessie Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Hey, Jess, how are you?
Good. How are you?
I'm good. How are you feeling these days?
Pretty good. Hanging in there.
Good. Yeah, I'm hanging in there too. I was under a little stress the other day, so I kind of went out for, you know how sometimes you have those really stressful days, you just got to go get a drink somewhere or something, right? Do a little unloading.
Absolutely.
So yeah, well, I went to a bar and I've got the weirdest story. So I'm sitting at the bar and I'm telling you what, a dung beetle walked in. A dung beetle walked into the bar. Can you believe that?
No.
Yeah. Yes. So it came in, strolled up next to me and he said, "Excuse me, is this stool taken?" Oh boy. So Jess, I'm really pleased to introduce our topic and our guest today. I know that one of the many topics on every infection preventionist's mind is antibiotic overuse and misuse, wouldn't you say?
Absolutely. It's really funny that you bring this up because there are actually Joint Commission updates to their elements of performance around antibiotic stewardship.
I saw that. Well, then this is a timely subject. So we have with us today Dr. Valerie Vaughn to talk about her article, Reducing Overuse of Antibiotics at Discharged Home, which is featured in the latest ACHIC, American Journal of Infection Control. Dr. Valerie Vaughn is an assistant professor and director of hospital medicine research at the University of Utah. Her research focuses on improving the safety of hospitalized patients by combating healthcare-associated infections and reducing antibiotic overuse, particularly during transitions of care. As a practicing hospitalist, she works to understand the role hospitalists play in inappropriate antibiotic use related to common infections such as pneumonia and urinary tract infection. She's also the hospitalist lead for an initiative to improve antibiotic use within the Michigan Hospital Medicine Safety Consortium. So she's very, very busy. Welcome, Dr. Vaughn. We're very excited to have you with us today.
Great. Thanks for that introduction, and thanks for having me here today.
Absolutely. So, we always start off with giving you the opportunity to tell us what prompted the research. So give us a rundown.
Yeah, well, as mentioned, antibiotic stewardship has been something we've been thinking about for quite some time. And the Joint Commission and CMS now require hospitals to have antibiotic stewardship programs. So this is something that's been going on for a while and really growing in scope. And that's been amazing to see. But one thing we noticed a few years ago now through that Michigan Hospital Medicine Safety Consortium collaborative that you mentioned that I work with is that a lot of hospitals are focusing on what happens in the hospital, so during hospitalization. But there's this blind spot at hospital discharge where all the best intentions from stewardship are maybe forgotten, or something happens and discharge is a busy and hectic time. And we see a lot of overprescribing of antibiotics at hospital discharge. In fact, we see that half of the antibiotic duration related to hospitalization happens after discharge. And a lot of it, up to 70% of antibiotics prescribed at discharge, are inappropriate. And other work that we looked at, kind of retrospectively evaluating programs and discharge prescribing, found that doing things just during hospitalization, so restricting fluoroquinolones, for example, doesn't necessarily lead to improved antibiotic use at discharge. What we also know is that stewardship programs can't be everywhere, doing everything at all times. So what we really wanted to do was to try to design an intervention that could use our partners in clinical pharmacy and integrate within kind of existing infrastructure around how does pharmacy talk to physicians, and try to design something to improve discharge prescribing that was feasible and could also improve prescribing.
Yeah, the whole article was very interesting to read. The whole project was very well organized, and Just wanted to say kudos to that. And we'll jump in. I had a question about the word iterative approach and strategy. You seem to use that multiple times in the article. So can you explain what that is?
Yeah, I think iterative is such an important part of these kind of studies. So often, and traditionally when we started designing interventions, you'd come up with a hypothesis in the beginning of what you thought was the best intervention. And you'd say, we're going to do this for a year and we're going to see what happens. And then on day one, you start and you realize for some reason that your intervention is completely flawed. But oh, well, you're going to keep doing it for another 364 days because that's what you said you were going to do. That's the typical study of a randomized trial. You don't change things along the way. It helps to assess outcomes. But the problem is if you're not 100% sure that it's the right thing, you could be doing something wrong and realize very early on that it's not going to work, but keep kind of moving forward just because that's what you said you were going to do. And so what's nice about an iterative strategy is you say from the beginning, we're going to learn along the way. And by our best hypothesis, we're going to start with A. But if we realize that A is not working, we're going to change it. We're going to be flexible and we're going to allow ourselves to learn from the end users, from the stakeholders, from the people doing the work on the ground and change the intervention as we can. And that way at the end, what you have is kind of a well-developed, well-designed intervention that then if you want to do a randomized trial, a cluster randomized trial, something like that, you have kind of a tested intervention that has worked because you've worked all the kinks out. And so one example of how we were iterative is that we designed ahead of time. We kind of thought, okay, well, it's hard for clinical pharmacists who aren't getting intensive training in infectious diseases to give recommendations about really complex patients, right? Like those with transplant, those with immune compromise and things like that. So let's exclude those patients. But what we heard from our pharmacists very early on as we started going is they were spending so much time excluding patients that they were spending very little time actually intervening on patients. And they felt confident in a lot of patients actually making recommendations. Sometimes it was just because there was already an infectious disease note and they were acting as the middleman, kind of making sure that the hospitalist had actually read the ID note and was doing things appropriately. So they were acting as a second check. So we found that they were helpful even in those patients that we initially thought they would feel uncomfortable helping with. So we were able to make that adaptation early on instead of continuing to make them do all this work excluding those patients.
That's really cool. And it also sounds like in the long run, it would save you time because you haven't committed to this one process, but you were able to change it as you moved along to develop actually what ends up being a better process. But so one of the questions I had is what interventions were implemented as part of this research and why were those specific interventions chosen?
Yeah. So what we really decided to do was to do kind of an antibiotic timeout that was led by the clinical pharmacists on the team and to give them kind of a 4-question timeout to go through to help kind of prompt this discussion. And the goal was to go through kind of four questions that we knew were really related to appropriateness of antibiotic use. So the first was, do you still think a bacterial infection is the most likely cause of a patient's symptoms? If the answer to that is no, we should stop antibiotics. So that question kind of is supposed to trigger a discussion about what's the most likely diagnosis. Can we stop antibiotics altogether? And if the answer is we can stop antibiotics, then you're done with the timeout. But if the answer is yes, I still think it's a bacterial infection, or yeah, it's most likely, although there could be something else going on, then you move on to talk about, is the preferred oral antibiotic being prescribed at discharge? So thinking here about spectrum, thinking here about dose, clarifying allergies and whether those allergies are real. And then the next question is, are you planning on prescribing the antibiotic for the preferred total duration, taking into account what they've already gotten in the hospital? So for patients with pneumonia, that's 5 days, things like that. So that was the third question. And then the fourth question was, have you documented or do you plan on documenting all of this in the discharge summary in order to facilitate communication with both your patient and the outpatient provider? So in our prior work, we found that those were kind of the 4 elements to appropriate antibiotic use at discharge? Was the antibiotic necessary? Was the spectrum correct? Were they avoiding fluoroquinolone antibiotics when they were able to? Was the duration correct? And was it communicated well? And then the reason we chose to work with our clinical pharmacists is we know that interventions done by infectious disease pharmacists or stewardship pharmacists or ID physicians can be very effective as stewardship, but there's a limited bandwidth, right? So you can't just ask your stewardship leads to do all stewardship in the hospital. And we thought discharge was actually a really good time to delegate some of that responsibility to clinical pharmacists who might not have the same strength of stewardship training, but they actually sometimes have a closer relationship with the team they're working with. So they're really integrated in the workflow. There was already a process designed for this hospital where the pharmacist and the hospitalist got together face-to-face to run the list in the afternoon. So this was just adding kind of a discharge timeout to an already existing process. So what I also think is really important to keep in mind for other hospitals is this might not be the perfect intervention for all hospitals because we had an underlying time, face-to-face interaction between these two groups. Your hospital might have something different. And I think it's really important to know what is existing and try to build in some sort of intervention into that existing workflow.
Yeah, I think that's really cool, especially the fact that they had that face-to-face time to discuss the patient before the patient was discharged. Because I think you're right. I don't know that necessarily always happens due to time constraints. But so thinking about moving from the interventions to the actual implementation plan, it sounded like there were some staff champions that provided some education around the process. Can you talk a little bit about how this education was developed and if it was thought to be successful as one of the interventions?
Yeah, so I'll say my two kind of rules of thumb for education for quality improvement like this is to have a lot of data and to have the education given by people that are trusted. So we use very similar kind of educational talks, slides, and information for hospital medicine physicians and for the pharmacists, but they were given by different people. So the hospitalist kind of led the education for the hospitalist and the pharmacist led it for the pharmacist. And we actually had the other champions attend in order to, answer questions and show their support. But I think it was important to have the education come from a trusted person. And then I say data, lots of data. We provided high-level stuff, but we had data on how often antibiotic overuse at discharge was happening, what the types of overuse looked like, how we saw that affected patients, data related to that. And through the Michigan Hospital Medicine Safety Consortium, we were actually able to have our individual hospitals' data benchmarked compared to other hospitals in the collaborative. So we find that for physicians, I can speak to this in particular because I am a physician. I know that we really like to at least say we practice evidence-based medicine. There's a lot of work that says that sometimes that doesn't happen, but we believe ourselves to be practitioners of evidence-based medicine. So as much as you can in the beginning, provide some of that hard evidence and show where your hospital currently lies in discrepancy to that hard evidence. That's really helpful, I think, to motivate people to change.
Mm-hmm. It sounds like you had a whole team working on this, so I'm going to use this as a chance to yet again plug how important multidisciplinary teams are. I'm always looking for ways to show how important that is. But who conducted the education? Was it from physician? Was it physician-led, or who was that?
Yeah, so again, I think it was important to be led by the people who were being educated. So we had our hospitalist champion educate the hospitalists, and we had our our pharmacist champions educate the pharmacists. And I'll just say again, we could not have done this study without our pharmacists. They were absolutely amazing. They helped us think through things that we would have never known about workflow, about how they could document to actually help improve the capture of outcomes. And we wouldn't have known that just as like physicians coming in telling the pharmacist what to do.
Right.
Them helping to design the intervention and being champions and then providing the education to their colleagues was critical to the intervention's success.
Right. Yep. Multidisciplinary and interdisciplinary teams. So, and the timeouts were performed with hospitalists, clinical pharmacists. You had antimicrobial stewardship teams, which I call AMS. So if you hear me say AMS, that's what I'm referring to. And I know that most AMS teams include like an infection preventionist, an ID physician, pharmacy. So who participated in the AMS team for your hospital, and how were they involved in the timeouts?
Yeah, I want to clarify here that the AMS team was not actually involved in the timeouts.
Okay.
They were involved, though, it was critical to get their support because you don't want to do anything involving antibiotic stewardship without your antibiotic stewardship team. They helped us design the guidelines and made sure that they were completely supportive and on board with the education we were giving, the pocket cards we were handing out, and kind of help spread the word. If they were being asked to give a talk or talk about something, they would flag the work we were doing. Mm-hmm. So they were critical partners, but stewardship teams have a lot of things on their plate. And so the goal of this was to try to take something off their plate and delegate it to the clinical pharmacists who are not technically part of the stewardship team. These are the pharmacists that are doing daily review of all medications. They're dosing anticoagulants. Mm-hmm. They're, doing vancomycin dosing. And they do some stewardship, but they weren't focusing on stewardship at discharge. So it was a little bit of trying to bring that group in. One thing that is really nice, though, at this hospital is that if the clinical pharmacist ever has a question related to antibiotics or antibiotic stewardship, they had the stewardship pharmacists or the stewardship physicians as a resource to reach out to, whether that was to try to have a direct conversation with the physician if they thought the physician was, maybe not doing something ideally, or to clarify and ask questions if they were confused about a guideline or a recommendation. So the stewardship team was involved kind of in that realm because they were there as a resource if there were questions, which is really helpful. But the stewardship team at this hospital is actually quite a behemoth because it's a huge hospital with outpatient clinics. And so there are many infectious disease physicians, pharmacists. We have hospitalist champions from different specialties, surgeons, et cetera, infection preventionists, healthcare epidemiologists, everybody that we can kind of meets together for this large group. So it's actually a very well-resourced program. And one thing we want to move into next is the reason we chose clinical pharmacists is because we think that's something that you can take to other hospitals that may not have even an ID physician on staff, right? There are some hospitals that only have an ID physician that comes by once a week or 3 times a week. So we wanted to take a group of people who were available everywhere so that hopefully we could translate this work to smaller hospitals with less resources.
I think that's amazing. And just listening to you talk about the team and the variety of stakeholders that were clearly very engaged in this work is really inspiring. And I'm already talking with the folks at our hospital about like what they're doing and potential plans for the future based on just, reading about this research. So I just think it's really cool. And the other thing that I thought was really interesting when I was reading through was that the researchers actually observed the antibiotic timeouts while they were happening in the moment. So in thinking about that, as an infection preventionist, we do a lot of hand hygiene auditing. And we have this thing we talk about a lot, the Hawthorne effect, where in the presence of the observers, people tend to have different behaviors. Do you think that there was any of this, or do you think that it was basically just what it would have been?
I have to be honest and say I think people definitely changed their behavior if I was standing next to them, right? They knew I was the one who helped lead this project. And, if I was standing there staring at them, I think they probably adhered to the pocket card questions a little bit better. But that's why we did data from multiple different sources. We looked and we asked hospitalists what their kind of recall was of how often they were asked these questions. And we saw that, they felt like they weren't asked question 1 about, do you think this patient has a bacterial infection? And question 4, reminding them to to document, they weren't asked those two questions as much as the middle two, which is duration and spectrum. And we actually saw that in our observations, but they reported it even more. So I think this is one reason why it's so important to get data from as many different sources as you can. And we had almost too many sources because it was very complex to try to explain it in this paper. But we got very rich data from our observations that we wouldn't have been able to get by surveys. And then the surveys help to, I think, describe exactly what you're saying, is that there may have been some Hawthorne effect as well from us observing.
I love the Hawthorne effect, honestly. I love watching people run to the hand hygiene. I call it the little hand hygiene dance when they see you, because they'll come out of the room very elaborately doing their hands together like it's they're doing some sort of dance with their hands. So I love that.
I agree.
So let's talk about some of your success and your outcomes. Tell us, how was success measured, like relative to the interventions and antibiotic use?
So I think our biggest goal really was to make sure that this was a feasible intervention. And that's because like I said, we designed it to be within the workflow of the pharmacist. And we wanted to make sure that we had done that successfully and that the physicians felt like this was appropriate and that they felt like it worked. And so that was our major thing that we were looking at. And we were very, I think, successful in that side. In talking to the pharmacist, it was a very feasible intervention. It really did fit within what they were doing. Each time out took maximum or kind of on average 2.5 minutes. The hospitalists, 85% of them believed that the intervention improved antibiotic prescribing. And so we really saw that the intervention was feasible and that there's a lot of excitement to keep doing the work. We only did the intervention for 6 months, so we weren't really powered to look at changes in antibiotic use over time. That's one thing when you're doing a pilot study instead of a large study. You don't always get to see that change in outcomes. But based on the data we did see, we saw that about a quarter of the timeouts resulted in a recommendation by the pharmacist to make a change, and then about 70% of those recommendations were accepted by physicians. So I suspect if we had had a larger period of time, we would have seen a change in antibiotic use as well. But I think what this showed us is kind of a proof of concept that this is something that could work and potentially be disseminated to other hospitals to look at hard outcomes.
Mm-hmm.
Yeah, I thought the data was definitely very interesting when reading through, and I also really appreciated the specific interview questions and the answers that were given. But one of the things that came to mind in reading through the analysis was whether there were any outcomes that were or interventions that were more effective than others to produce the outcomes that we were hoping for.
Yeah, so I mentioned already that questions 1 and 4, so the one about do you think this is a bacterial infection and the one about documentation were the ones least likely to be asked. What we found that was really interesting is that do you think this is most likely a bacterial infection? Very few people stopped antibiotics altogether as a result of this timeout because of a change in diagnosis. And we actually started... This was surprising for me because I deep in my heart believe that discharge is a great time to reconsider your diagnosis and say, we've been treating this patient for heart failure, for COPD, and for pneumonia. Which one do we actually think that is now? Okay, it's heart failure. Let's stop the antibiotics. So I think it's a brilliant time to do a diagnostic timeout where we stop the infectious diagnosis. But what I learned through this process is, as much as I believe that to be true, pharmacists in general don't believe that to be in their scope of practice, right? They believe medications are in their scope of practice, but diagnosis is something that physicians do. And so for them to try to challenge someone else's expertise, if they don't feel comfortable in it, it just doesn't work. And so they didn't feel comfortable asking that question. Physicians didn't really feel comfortable in receiving that information from a group that they didn't feel was an expert in diagnosis. So that part of the intervention is probably less effective. And then the other thing that was interesting, so that is a piece that I think we're going to have to think about how to do that differently because this isn't as effective. And then the other piece was the documentation. the reason that we asked people to do that is because we found documentation was actually an area of concern, where there wasn't a lot of good documentation. And in a retrospective review, we'd found that if you document your antibiotics, they actually end up being more appropriate, potentially because you're stopping to pause and actually calculate your duration and think about what someone is going out on. So we thought that was really important. But again, this is kind of at this time, what was funny was we actually saw during some of our observations the incredibly defensive reactions from the hospitalists that were like, of course I'm going to document this. Like, I always document this. What are you talking about? But the funny thing was we saw an increase and an improvement in documentation as a result of our intervention. And there have been kind of studies in the past that are really funny that basically say if you have an emotional response to feedback, you're more likely to actually remember it and do better. So it does make things awkward for our pharmacists, but it was maybe the most effective piece of the intervention. So we'll see about that going forward. But that was kind of a funny observation.
Yeah, that's interesting. I never thought about that, but that makes sense because throughout life you kind of think about those are the moments that pieces of information and moments you remember the best. With that emotional connection. Very interesting.
Yeah, absolutely.
So one of the other things that the article talks about is the use of the pocket card for assisting the providers and pharmacists through that conversation in making those appropriate decisions. And I think we talked about those 4 questions that they're asked. So we know that they included the questions about the duration, dosage, bacterial infection, and then I can't remember the last question, but so based on those observations, did the providers actually find those cards useful at all?
Yeah, so this was another place where it was very interesting and different by discipline. So the pharmacists, because they were using the pocket card as the intervention, had it almost all the time, unless they'd had it memorized or forgot it in their office or whatever. But the physicians didn't have it, never referred to it. And when you asked them why, they were like, well, I knew the pharmacist would have it. And if you think about it, physicians, and I'm a hospitalist too, so I know what this is like. Antibiotics are one of 40 different things that you're thinking about, right? Like, I'm also thinking about what's the heart failure medication I'm supposed to be prescribing now, or what's that new diabetes med? Like, it's so broad what we have to remember to do that we'd have to carry around like 40 pocket cards in order to have all of the pocket cards for all of the things that we have to think about. So if we can remove some of that from our brain space because we trust the pharmacists are going to have it and be telling us the right things, we're going to immediately do that, right? Because then we only have 39 things to think about. So that's what we found, is that once they saw that pharmacists were like reliably bringing the pocket card and providing those recommendations, they weren't worrying about it anymore.
Smart. Yep.
Yeah, and I think that was reflected when it said that 61% of the observed timeouts, the pharmacists actually referred to the cards, but at 0 time did the hospitalists refer to the cards. So I think that highlights that in the data.
Mm-hmm.
Yeah, absolutely.
So let's talk about some of the constraints that were discovered during the trials and some of the solutions that were found. I know in particular you had issues with off-hours timeouts.
Yeah, I think one nice thing about discharges is at least you don't get typically discharges at 2 o'clock in the morning, right? You might get antibiotic starts at 2 o'clock in the morning. So that's always an issue you think about for stewardship, is how do you handle things that happen in the middle of the night? Fortunately, discharges tend not to happen in the middle of the night. They tend to be planned in some way. But weekend discharges are a big thing. And so that was something that we really had to think about. We tried to build that into the Friday timeout. So timeouts happen Monday through Friday. And on Friday, they would kind of prompt people to discuss anticipated weekend discharges. But I'll tell you from clinical practice, I'm never right in predicting when my patients are going to go home. So they can be very, very unexpected. And so we still missed unexpected discharges. Mm-hmm. And I don't think we have an amazing solution for that yet. One thing we could think about doing in the future is just on Friday saying, if this patient were to go home over the weekend, what would you do? That way it's like you have that information, sure, whether or not they actually go home.
Like a Boy Scout, you're prepared. Always be prepared.
Exactly. Mm-hmm. Yeah.
And hospital interruptions. The article talked about interruptions during the timeout, including one that almost led to a mistake. And I know in the surgery setting, it's essential that everyone in the room stops what they're doing to have an uninterrupted timeout. And I think the paper mentioned that the antibiotic timeouts lasted about 2.5 to 5 minutes. So do you think that it's feasible to implement a hard stop what you're doing to focus on the timeout in this particular setting?
I think it's really hard. And I saw that you guys were going to ask me this question, and I was like, oh my gosh, that's a great question. And I don't know if I have the solution, because this is not a problem just for antibiotic timeouts. I now have on me 3 different ways to be paged, right? Like one comes from nurses. One now everybody uses their cell phone, so I can get called at any moment. And then I have like an emergency page. And on certain days, I'm carrying the code pager. And that was one that we saw as well, is like the answer to some things is no, because one person got up and ran away in the middle of a timeout because their patient was coding, right? So you can't have uninterrupted time in that situation because they have to run away. So it's hard. And I don't know if I have a good solution for that, because we haven't done a good job of making our, when we started this phone call, I loved that you guys asked me to turn off my phone and turn off my email. That doesn't work as well in the clinical setting because we don't have a good way of triaging, like, this is a page that could wait versus you need to answer this page immediately. We don't have that yet.
Right, because in the OR setting, that whole team is there for that one specific patient to do this one specific job. But in your setting, there's a variety of patients being taken care of all at once. So I wasn't sure because I love the idea of the timeout, but a timeout also denotes everybody stopping and focusing on that. So there's a lot of moving parts that looks like you just have to smooth out.
I think one thing that I would do in the future with kind of the education with pharmacists is I saw sometimes they would keep talking even though a physician was reading their pager, and then they would just keep going on as if the physician had heard them while reading. And that's not true. You can't be reading a pager and listening to something someone's telling you. So from the pharmacist point of view, if you see someone's attention turn away because they're reading a page or a colleague comes in the room, you pause the conversation. And then when they turn their eyes back to you, you restart the conversation. I think that's one thing we could teach our pharmacists to do.
It's funny that you say that because I just told my 10-year-old the other night that she couldn't possibly be watching something and listening to what I was saying to her. And she said, of course I can. I said, that is not true.
I agree with you.
So I thought the 2 minutes to 5 minutes thing was really great too, because if you think about that sort of as a standalone time frame, it doesn't seem like a lot, right? Like that's not a lot of time to spend. But then when you think about cumulatively how much time is being spent by both of those individuals, I imagine that it could end up being a significant amount of someone's day. But additionally, what I thought was interesting was that 52% of the physician respondents thought that the discussions with the pharmacist were helpful and helped them make a decision about the prescribing at discharge. But when asked how often the pharmacist's suggestions were accurate, 96% agreed. So it sounded like they felt like that the pharmacists were accurately making recommendations, but only 52% of the time they thought it was actually helpful. So what do you think that means?
I'd really have to read between the lines here, but I suspect this is something along the lines of, them reacting to being told to document, which is, yeah, I was going to do that anyway. Like, they didn't change my opinion. I was definitely going to, de-escalate and prescribe a short course duration anyway. I mean, what they were telling me was right, but I was going to do that anyway, so it didn't help me. But the question is, was it really going to, were you really going to do that? Did it remind you, like you might have forgotten otherwise? Or did it allow you to, make that decision more easy? Because I'm telling you, every decision I have to make every day as a physician, it's just the cumulative effect of making 200 decisions a day is so exhausting that having just one less to make because, oh yeah, the pharmacist already told me to do that, so I can just change it, is so nice. So I think there's the difference between what we say is was I going to do that anyway? And so didn't it change what I was going to do? And so I'd love to see this whole thing done in a large enough group to study the effect on antibiotic prescribing, so that we can show that it does really work, even when people say that, oh, I was going to do that anyway.
Well, I'm looking forward to talking to my clinical pharmacist about this. So thank you so much for all of the research that you've done. What are your biggest takeaways for us today?
Yeah, I mean, I think what this showed is that clinical pharmacists can be excellent antibiotic stewards. And I think that's really exciting for stewardship in general, because we need as many people as we can to be engaged in this. And our clinical pharmacists were absolutely outstanding and great partners.
Well, thank you again for being with us, Dr. Vaughn. We really appreciated having you on. Great conversation. And we just can't thank you enough for your research and speaking to us today.
Thanks for having me.
We are Nicki Shorr and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business. To hear other AJIC podcast episodes and to access information about this podcast in the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AGIC, scienceintopractice.org.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology, with input from the APIC Research Committee and Pat Stone and Jean Brandt at AJIC, and APIC staff Lisa Tomlinson, Liz Garman, Bobby Gulshan, Chris Ruiz, Kelly Lynn Russell, Sylvia Quevedo, Kaylee Deaton, and Christine Miller. We work in partnership with Human Factor and audio tech Blake Alton.